Okay, so picture this. You walk onto the ward, the emergency buzzer is just screaming. Your patient is deteriorating. In fact, the monitor's flashing, their NUWS2 score is climbing into that red zone, and you see two junior nurses trying to manage, clearly overwhelmed. You've got multiple demands hitting you all at once. Someone's shouting for IV access, another for oxygen. The senior doc is on the phone. Oh, and the family have just arrived. What? What is the single most crucial thing you do in those first 10 seconds?
And that right there is the ultimate test of leadership, isn't it? It's that moment where all your clinical knowledge just collides with pure chaos.
Right.
And that first 10 seconds, that's where people make the high-scoring, safe decisions. Or, well, they fail to establish any kind of control.
Welcome back to the deep dive. Today, we are focusing on that brutal reality of time-critical decision-making. Our source material comes from key professional assessments and textbooks, all focused on emergency leadership. We're drawing on the interface between clinical protocols, your RCUK and NICE guidelines, and those essential non-technical skills.
Human factors based.
Human factors, exactly.
Our mission today is to sort of synthesize those two worlds for you, because you already know the algorithms, right?
Yeah.
But knowing how to lead the people running that algorithm, well, that's what saves time. And it saves lives.
So it's not just about the diagnosis?
Not at all. Leadership in these moments is about coordinating people, information, and equipment, all under this massive time pressure. We're trying to give you that shortcut mindset, the instant structure you need to deliver guideline-based care.
Okay, so let's jump straight into that essential structure. If we had to boil all this guidance down to one powerful truth that should govern every decision in an emergency, what would that be?
It's a bit tough to get it into one sentence, but I'll try.
Yeah.
The core truth is this. Visible structure is a primary currency of safe emergency leadership.
Visible structure. So not just knowing what to do, but making sure everyone sees and hears what you're doing.
Precisely. And if we unpack that, it really means 6 immediate actions. You need to call early, allocate roles clearly, run the algorithm out loud, keep a timeline, escalate based on triggers, and document everything meticulously.
That whole list, it just seems to cut right against that temptation to be the lone hero, doesn't it?
It does.
We all know that feeling. The adrenaline rush, you want to grab the defib yourself, start the IV because you think I can do it fastest. Why is the high-scoring, safest mindset so against that?
Because your personal efficiency it plummets. It drops to 0 the second you try to manage the airway and the compressions and the timeline all at once. The sources are really clear on this. The highest marks go to actions that show early help seeking and that visible structure.
It's about protecting the patient.
It is. It reduces delay, and critically, it eliminates duplication of effort. Lone heroics are just. They're unstable. They're error-prone, especially when you get to complex things like drug calculations or maybe the most dangerous part, losing track of time.
So we've got these two pillars then that you can't separate. The clinical frameworks, let's call that the what, and the non-technical skills, the how. Can we define those a bit more clearly? What's in the what?
So the what is your clinical bedrock. This is the stuff you know from your training. The algorithms, like the ALS protocols from the Resuscitation Council UK, that means high-quality compressions, identifying the reversible causes, the 4 H's and 4 T's, and early defibrillation.
And just for anyone listening who might be a bit less familiar with that jargon, the 4 H's and 4 T's, what are we talking about there?
Right, good question. So the 4 H's are hypoxia, hypovolemia, hypokalemia, and other metabolic issues, and hypothermia. The 4 T's are thrombosis, so a clot on the heart or lungs toxins, tamponade around the heart, and tension pneumothorax. A great leader runs through these out loud with the team.
They don't just keep it in their head.
Never. And beyond ALS, the what also includes things like the NICE guidelines for sepsis, which is all about recognizing risk and getting antibiotics and fluids in quickly, and of course using new WS2, the National Early Warning Score, as that standard tool to spot when someone's deteriorating. Okay, that's the clinical side. Now for the how, the non-technical skills. This is where the leadership becomes visible, right? Absolutely. This is the human factors bit, or crisis resource management. It's the difference between just being a smart individual and being part of an effective team. It demands clear role allocation, absolute commitment to closed-loop communication.
We'll come back to that.
Definitely. And also maintaining high situational awareness and escalating at the right time. Study after study confirms this stuff, these non-technical skills. They drastically improve patient outcomes because they lower the cognitive load on everyone when you're under peak stress.
Okay, let's unpack this then. We need that first last framework absolutely locked in. What is that instant sequence that saves time and, scores the highest marks?
Step 1. It's always the same. Activate help early. If the patient is unstable, if they're deteriorating, if they've arrested, you hit the emergency buzzer or dial 2222 before you do anything else.
Before you even touch the patient.
Before you touch them. That action buys you your most valuable resource, which is capacity, more hands. Delaying that call was a fundamental breach of risk mitigation.
But once that buzzer's hit, the cavalry's coming, but the chaos doesn't just stop. It might even get worse as more people arrive. So step 2 has to be about creating order from that chaos.
Exactly. Step 2, allocate roles out loud. You have to visibly take the lead and start giving out jobs. And it doesn't matter if you're the most junior person there. If you're first on scene, you lead until someone more senior formally takes over. It prevents all that confusion and people doing the same job twice.
This is where those model phrases are so important, isn't it? If I'm suddenly in charge, what am I actually saying?
You need to be loud, you need to be clear, state your role, then assign the others. So a classic phrase would be, I am team lead. Alice, you are airway. Ben, you are compressions. Chen, you are drugs and defib. D, you are scribe and timekeeper.
And then you get them to confirm.
Crucial follow-up.
Yeah.
You have to ask them to confirm their role back to you. That's the start of closed-loop communication.
So for our listener, how does that closed-loop communication work in practice? Can you give us a quick example? Why is it so good at preventing errors?
It's so simple, but it's revolutionary. The leader gives an instruction. Give 1 milligram of adrenaline. The recipient says it back, giving 1 milligram of adrenaline. And then, this is the most important part, they confirm when it's done. 1 milligram of adrenaline given.
Ah, so there's no ambiguity. It's not just prescribed. You know it's been given.
Precisely. It prevents that catastrophic error where a drug is ordered but never actually administered. It closes the loop.
That makes perfect sense. So step 3 must be about getting on with it.
Step 3. Run the algorithm visibly. So you follow the RCUK, or the sepsis bundles protocol, precisely. This means having a timer running and, ideally, using a visible checklist if there's one available. It just standardizes the care and stops steps from being missed under all that pressure.
But the situation is always changing. How does a leader make sure they don't get tunnel vision?
That brings us to step 4. Maintain situational awareness through micro-huddles. There's this idea of a PACE-10 framework, which basically just means you schedule very short pauses, a 30-second regroup every 2 to 3 minutes, or maybe when you're switching between phases of the algorithm.
So it's not waiting 10 minutes. It's about a planned, scheduled pause for thought.
Exactly. It's a moment for the leader to literally take a step back and think, what's next? Do we need more IV access? Have bloods been sent? What about imaging? Has anyone discussed ceilings of care? It's also the perfect time to brief a senior who's just arrived using something structured like SBR.
Speaking of seniors, step 5 must be about escalation.
Step 5. Escalation and coordination. High NUWS2 scores, 7 or a 9, or hitting the full sepsis criteria. These are hard triggers. They demand prompt, clear escalation. You have to get the senior review, ICU outreach, or the rapid response team involved early. Your job as a junior is to make sure the right people know how sick this patient is.
And then wrapping it all up. Whether it's a good outcome or a bad one, there's always step 6.
Step 6. Close and document. This is just non-negotiable, but it's so often forgotten in the heat of the moment. Meticulous recording of what happened, the exact times of drugs and shots, the decisions made. It's vital for continuity of care and vitality. Well, for medical legal reasons. If you didn't write it down, legally it didn't happen.
Okay, here's where it gets really interesting for me. We've laid out the perfect structure, but in that adrenaline-fueled moment, so many people hesitate. They think stopping to allocate roles is a waste of time. How do the professional exams and how does reality tempt us into making those low-scoring mistakes?
That hesitation is the #1 trap. You feel like you'd be faster grabbing the equipment yourself, but the moment you do that, you've become the bottleneck. You are the rate-limiting step for every other action. The traps reward immediate but unstructured action.
Whereas the high-scoring choice is always structured.
Always structured, delegated action.
Let's run through some of those specific pitfalls then. The things that guarantee a low score.
Okay, trap #1. Wait for a senior before acting. The reason this scores so badly is profound. You are losing critical, irreversible time where that patient should be getting basic life support. High-quality compressions, oxygen.
You're just watching them die.
Essentially. Delaying breaches that fundamental principle of early activation. You start the protocol, you get the structure going, and then the senior can take over when they arrive.
Right. What's trap #2?
Trap #2 is do everything yourself silently. This is the lone hero trap. The consequence is just unsafe, unsustainable care. You'll miss things. You'll forget the documentation. You won't call for the blood gas. You'll miss a reversible cause. It's chaotic multitasking, and it's not acceptable.
And if the algorithms are the standard of care, then ignoring them.
That's trap number 3, ignoring algorithms, new WS2, or sepsis triggers. The rationale here is simple. You're failing to escalate. If a new WS2 score is 7 or higher, the system demands a rapid response. Choosing to just monitor hourly or review later when those criteria are met is a fundamental breach of safety guidelines. It leads to catastrophic delays.
And let's not forget the end of the process.
Trap number 4. Treat first, document later, or not at all. The consequence here is poor continuity. The next team has no idea what happened, and it exposes you to huge liability. All that valuable data, the exact time of a shock, the first dose of antibiotics, it's just lost.
This structured approach, it just sounds like it aligns perfectly with the GMC's expectations of us as clinicians.
It does, completely. These high-scoring actions directly map onto the core GMC anchor points. Working effectively with colleagues, responsible delegation and escalation, and keeping clear, accurate records. The assessment is just testing if your behavior under stress meets those professional duties.
Okay, let's talk about red flags. What are the critical moments where a leader must intervene and correct what the team is doing?
The sources are pretty clear on 4 major red flags that show a breakdown in safety. 1, no one has actually called for help. 2, there are no clear roles, especially no scribe. 3, key triggers, like that NWS2 of 9, are being actively ignored. And 4, there's audible confusion about the patient's ceilings of care.
And if you see any of those,
You have to stop what's happening and fix it instantly.
But let's try and apply this structure. You mentioned the leader memory aid. Can you remind us what that stands for?
Sure, it's a great little mnemonic: leading call, establish roles, algorithms, dialogue, so closed loop, evaluate with micro-huddles, and record and escalate. It covers all 6 steps.
Perfect. Let's apply that to a classic sepsis scenario. Busy ED. Patient has rigors, their blood pressure is 84/56, risk rate of 28, and a lactate of 4.3. Their new WS2 score is 9. You've got 5 options.
Okay, so new WS2 of 9 is a massive, massive red flag. Your brain should immediately be screaming, sepsis. And, delay is catastrophic, so we have to activate the sepsis bundle immediately.
So you're looking for the most comprehensive option.
Exactly. The top answer will be something like Action A. Declare high-risk sepsis, start oxygen, fluids, IV antibiotics per policy, allocate roles, call the senior in ICU, and start documenting. It's early, it's protocol-based, it's structured, and it includes both treatment and escalation at the same time.
And why do the other options, like waiting for the shift lead or ordering more blood tests first, why do they score so badly?
Because they're just unacceptable delays. Waiting for the shift lead means you're just passively watching the patient slide into septic shock. Ordering more tests first means the patient is losing those precious minutes where the IV antibiotic should be going in. Sepsis is a medical emergency. You treat empirically. The tests follow, they don't come first.
Give us the model phrase for that sepsis scenario. What should the leader actually be saying?
Something clear and direct, like new WS2 is 9, this is high-risk sepsis. We're starting the sepsis bundle now. Alice, get IV access and send bloods. Ben, start 5 antibiotics per policy and a 500 milliliter fluid challenge. I'm leaving the consultant in ICU now. D, please start the documentation. Again, it's severity, protocol, roles, and escalation, all stated out loud.
Okay, let's pivot quickly. A ward arrest. You arrive first with a junior nurse and a healthcare assistant. The options are, say, begin compression silently, wait for the registrar, or call the arrest and assign roles aloud.
The choice is crystal clear. Calling the arrest and assigning roles is the only correct answer.
Yeah.
Waiting for the registrar. You're losing brain cells every second. The patient needs compressions now.
And starting silently.
That's the lone hero trap again. You've got no timekeeper, no one getting drugs, no one recording what's happening. You have to spend those first 10 seconds allocating roles to save the next 10 minutes from chaos.
So the moment you call that arrest, you are the team leader, no matter your grade, until you are formally relieved. And your first job is structure.
Absolutely. The first move isn't clinical. It's pulling the alarm and allocating roles to establish command and control.
So what does this all mean for you right now? Whether you're prepping for an assessment or just walking onto a busy clinical shift, let's boil this down to 3 key takeaways.
Okay, number 1, early activation and clear delegated roles will always beat lone heroics. Structure and visible leadership are safer than improvisation. You can't fail by calling for help too early.
Number 2, run the recognized algorithms, ALS, sepsis, anaphylaxis, with disciplined closed-loop communication. Just treat the protocol as the non-negotiable standard of care.
And number 3, use those objective triggers like new WS2 or the NICE guidelines to escalate promptly. And always, always document everything meticulously. Documenting is an extension of patient care, not an afterthought.
We focus really heavily on individual patient emergencies, that kind of micro-leadership in a small team. But these principles, they scale up, don't they? The first structured step you take in a cardiac arrest directly informs how you'd respond to a major incident.
It's the same skill set.
It is. Your ability to create instant structure in one trauma bay is the same skill you'd need to coordinate a whole hospital response. In the biggest emergencies, your first structured step is transmitting that methane message. So it really leaves you with a question, doesn't it? How do you take these foundational micro-leadership skills like assigning a scribe and translate them into macro-level coordination with bigger teams and bigger systems? Something for you to consider as you encounter more of those complex challenges.